like I said, a little bit more risque as we go along in life. All right, why do we put in chest tubes? Primary reason is the first one there, to evacuate any air or fluid that may be present within the pleural cavity. Conversely, to prevent any air or fluid from re-entering. So in the case of a post-cabbage, we'll have not only pleural cavity, but we'll also have it in the mediastinum. We'll have a chest tube to prevent air from re-entering in. Was that me? Oh man, what was that? And then also we have this process where we do a pleurodesis, where we're putting a substance in there to prevent recurrent pneumothoraces, and that's the agent that is commonly used there, the oxycycline. Can't see it really well on here. I can see greater on mine, but there is a definite spot here where you can just have a well delineated pneumothorax there. You can see there's no vasculature over there where there is on that side. So, again, mediastinal chest tubes are draining the mediastinum. When that's been opened and entry's been made into it, you need to have some mechanism to drain it. In intrapleural, we're going to go ahead and re-expand the lungs in the process. Small pneumothoraces, less than 20%, typically are not treated. They're just allowed to spontaneously reabsorb. Greater than 20% requires a chest tube. So that's where we get involved in pleural effusions, depending upon, regardless of its exudative or transudative. If the effusion is large enough that it's impairing ventilation and oxygenation, then we're going to go ahead and place a chest tube. If you remember back to 1140, transudates basically are ones with low protein counts, much more clear, no cells, where exudates are full of stuff, if you will. Often have indications of large-scale infections or malignancies, and there's usually a lot of neutrophils present. Some other definitions. We know hemothorax would be blood, chylothorax would be lymphatic fluid that is accumulating, hydrothorax where it's just some fluid of some kind, usually plasma, and an empyema or pyothorax are where it's disgusting pus that is accumulating in that space. And there's what is known as a succussion splash, that as you actually move the person, you can actually hear the water sloshing around on the inside. Here you can see in the upright position there's a definitive pleural effusion there. Total loss of the costophrenic angle. One, two, or even multiple chest tubes are necessary to drain the air. We're going to put it in the second to third intercostal, I don't know what the fourth, but second intercostal space, midclavicular line. Fluid usually is going in the mid-axillary line, and it's a little bit lower in where it's placed. So here where I put air, and here's where I would do it for blood. The size of the tube is somewhere between a 16 and a 36 French. So if you think back to your suction catheter, give you kind of a clue as far as how large these tubes are. And there needs to be some mechanism of a water seal, which is or a Heimlich valve, both of which will act as a one-way valve to allow air to exit the pleural space but not be able to re-enter again. Remembering we're always inserting it on the superior surface of the rib, and it's going allowed to slide into that interpleural space. Theoretically, you could have a one-bottle system. We don't see these used for any length of duration, but it basically allows us to allow the air to exit out of the intrapleural space until we can get something more sophisticated set up. And air escapes during the expiratory phase, where there's some positive pressure within the intrathorax, and bubbles out through the water and out to the atmosphere. It doesn't It's not a good system for when you have a lot of fluid that you're draining off, but in the emergent mechanism or emergent situation, it's beneficial. So here I have a one bottle where I just have a tube coming from the patient. It's submerged below a level of water, and I have a vent to the atmosphere, so when this bubbles out, it's evacuated out through that mechanism. Two bottle systems, then were a little bit more sophisticated. One was a water seal. The second one was just a collection bottle that would collect anything that was draining off. And we would see this mechanism called Tidaling, which is as the person, this is again collecting the fluid, but any air that is present then is allowed to go ahead and bubble through. And there's again that same vent to the atmosphere. The term tidling is referring to the rise and fall in the water level that occurs during spontaneous breathing. So during spontaneous breathing, there's a movement of fluid up on inhalation and a movement of fluid down on exhalation. Negative intrathoracic pressure during the inspiratory phase causes fluid to move up this tube, and during exhalation goes the opposite direction. With positive pressure, it's the opposite. So on inspiration with positive pressure in the intrathorax, you're going to end up seeing fluid move down the tube. Exhalation, then it returns back up again. When we don't see any tidling present, that's an indication that their air leak has been resolved or that there's an obstruction in the system. And we'll see it also, tidling occurring, when we're applying active vacuum, which is what we most commonly see with our 3-bottle system, where we add a suction control chamber. That suction control regulates the maximum amount of suction you could have. The water height will determine the amount of negative pressure, and that gentle bubbling that is there is indication that the suction system is working. There will be gentle bubbling on exhalation seen through the water seal bottle if there is drainage still going on. When you're seeing continuous bubbling, it usually is a sign of a pretty significant air leak still, and you need to make sure that it's not something within the tubing itself that is leaking. And as you go through initial drainage, you're going to end up seeing that. So here's a picture of the 3-bottle system that we're going to be probably encountering the most in the ICU. You have a port coming from the patient that's collecting any fluid that's being accumulated off. You go ahead then, and that's attached to the water seal, which is then attached to the suction source through this other tube here, D. And this one, C here, tells us what the maximum amount of vacuum that can be applied. You can never have more than the distance that this is submerged below the surface. It's kind of a limiting factor. And there are some 2-bottle systems where they combine the water seal and the collection, and it really should not be used for somebody who's got a lot of fluid that is being drained. This was actually literally the suction bottles were big glass bottles. Has anybody ever seen one of those in the ICU? I had a thoracic surgeon who used to insist on using them, and they're just so cumbersome, especially if you have to take the patient down to X-ray or something. More commonly, what we end up seeing is something called the Pleurovac. There's multiple names for it, obviously, but it has a combination of the suction control chamber on the left-hand side, the water seal in the center, and my collection chamber on the right-hand side. So it's kind of reversed from the pictures I had previously placed, but it still functions exactly the same way. And you can see that as this right-hand chamber fills up, it then spills over into the second, and then it spills over into the third, and hopefully you never get to a spot where you're draining 2,500 milliliters of fluid off because something's wrong with the system. You got that much fluid being pulled off, or that much blood being pulled off. And there you have one that's full. Not a real pretty sight. Here's one that's showing some of the chyle, the lymphatic fluid that's being pulled off. So our role, as far as assisting the physician, is to help position the patient and just be ready if there's any stuff that needs to be handed to them. They'll end up anesthetizing the site of insertion with just some simple lidocaine. They'll go ahead and do some conscious sedation. It should be Versed, shouldn't it? Let's change that right now. It's not Versed. It's Versed. And while the tube is, or while they're puncturing into the intrapleural space, taking a deep breath will move, will allow for a better insertion process. We know about how it's inserted, and then we get a chest X-ray once it's done. You want to watch one? Have you guys seen one? Good. Let's watch one.
This is a video of clinical medicine.
It's about 5 minutes. It's not terrible. Guy does a pretty good
Insertion of a pleural chest tube is often done in a setting
demonstration.
where action is required. Nonetheless, adherence to sterility, analgesia, sound technique, and safety are always warranted. The most common indications for chest tube drainage are pneumothorax that is recurrent, persistent, under tension, or bilateral, any pneumothorax in a patient on positive pressure ventilation, hemothorax, recurrent or symptomatic large pleural effusion, empyema, and chylothorax. There are relative contraindications, mainly based on hematologic abnormalities, such as bleeding diatheses or coagulopathy. Blood products or coagulation factors may need to be transfused in order to reduce the risk of bleeding during the procedure. The procedure should be explained and consent obtained whenever possible from the patient or next of kin. A chest X-ray should be performed when possible prior to the chest tube insertion. Sterilized and fully prepared chest tube trays are often available in the hospital. The key materials required in addition are a sterile gown, mask, and gloves, sterile drapes or towels, local anesthetics such as 1% lidocaine, chlorhexidine cleaning solution in sterile pieces of gauze, 25 and 21 gauge needles, 10 cc and 20 cc syringes, a scalpel with size 11 blade, which should be on the chest tube tray, at least 4 or 5 dissecting instruments, such as telecurved clamps or artery forceps, which should also be found on the chest tube tray, non-absorbable strong sutures of size 1.0 or greater made of silk or nylon, a chest tube of appropriate size, a sterile drainage system, and dressings for the tube after insertion. The chest tube is sized according to its internal diameter. The length of the tube is marked with numbers to indicate distance into the chest wall. Additionally, there are several drainage holes at the distal end. A radial opaque stripe runs along the length of the tube and outlines the most proximal drainage hole. This is used to confirm correct placement of the chest tube in the pleural space on a chest X-ray. Choosing the size of chest tube is based on the indications for the tube. In the case of a large pneumothorax in a clinically stable, spontaneously bleeding patient, chest tubes with an internal diameter of 16 to 22 French may be placed. In a patient with a large pneumothorax who is clinically unstable, the same rules for chest tube sizes apply. However, if the patient has underlying lung disease, requires mechanical ventilation, or is anticipated to have a large air loop, larger tubes from size 24 to 28 French are recommended. In order to drain a viscous hemothorax or empyema, or to evacuate a pneumothorax in a patient receiving mechanical ventilation, larger diameter tubes sized 28 to 32 French are more often employed. Newer evidence favors the insertion of smaller size 10 to 14 French catheters, or pigtail drains, for the drainage of pneumothoraces in clinically stable patients, and for malignant pleural effusions. This is done using a Seldinger technique with a guide wire and often with ultrasound guidance. This technique differs from that used for larger chest tubes and will not be discussed further in this video. Once the chest tube tray is open and all the key instruments are identified, occlude the proximal free end of the chest tube with a clamp or forceps. Next, with another clamp or forceps, grasp the distal end of the tube. This will aid in passing the tube through the tract. The patient should be positioned either supine or in a semi-recumbent position. The ipsilateral arm may be maximally abducted to the side of the patient, or, alternatively, positioned behind the patient's head in order to have optimal exposure of the insertion site. The ideal location for the placement of the chest tube is in the triangle of safety, the anatomical region defined by the lateral border of the pectoralis major muscle anteriorly, the mid-axillary line posteriorly, which is also the anterior aspect of the latissimus dorsi, the apex just below the axilla, and the horizontal level of the nipple inferiorly. The nipple line may be an unreliable landmark for female patients due to breast tissue. To help with landmarking, remember that the triangle of safety should approximately lie between the fourth and fifth intercostal space and the anterior axillary line. Start your landmarking by localizing the clavicle. Next, count the rib numbers as your fingers traverse down the anterior chest wall. Once the correct intercostal space is found, move your hand along the space laterally towards the anterior axillary line. The incision will be made here. The chest tube will actually be inserted 1 interspace above this point. Mark the incision spot with the imprint of the back of a needle or a pen marking. Once full barrier precautions are employed, use the chlorhexidine cleaning solution in sterile gauze to create a large sterile field on the patient's skin. Cover the field in sterile drapes so that only the procedure site is exposed. Adequate analgesia is a very important step in this procedure, as chest tube insertions can often be very painful for the patient. The skin, subcutaneous tissues, deeper tissue layers, parietal pleura, and periosteal surface of the rib below the intended insertion site must be generously anesthetized. Using the smallest gauge needle, create a wheel of anesthetic in the skin overlying the landmark spot. Using the larger needle, anesthetize the subcutaneous skin layers through the wheel, aspirating as the needle moves deeper. Anesthetize the periosteum of the rib that lies below the intercostal space where the tube will be inserted. Once the parietal pleura is encountered, a flash of pleural fluid will fill the syringe if a pleural collection is being evacuated. If a pneumothorax is being drained, the syringe may only fill with air as the needle enters the pleural space. Withdraw the needle, aspirating along the entire path. Make an incision approximately 1.5 to 2 centimeters in length above and parallel to the anesthetized rib.
This is why you're not going into surgery.
Introduce the curved dissecting instrument, such as the Kelly clamp, into the incision. Begin dissecting the subcutaneous tissues in order to reach the intercostal muscles. After dissecting the subcutaneous tissues, stay on top of the rib to guide the blood dissection. This will create a diagonal path towards the correct intercostal space. When using a larger chest tube of sizes 24 French or greater, use your index finger to explore the tract created by blood dissection.
I've actually had students, the doc says, do you want to get your finger in there?
Once you have dissected the subcutaneous tissues and deeper intercostal muscle layers, you will encounter the parietal pleura. Push the clamp gently through the parietal pleura. The entry into the pleural space through the parietal pleura
Now we're in.
is felt as a give or a sudden release of resistance. Alternatively, you may use your finger to penetrate fluid to the pleural space. Once the pleural space is entered, use your index finger to ensure the lung is not adherent to the chest wall, which may impede passage of the tube into the pleural space. Often, pleural fluid will trickle out through the tract, further confirming entry into the pleural space. pass the tube through the incision, unclamp the jaws of the kelly, and then direct the tube through the tract slowly using the finger as a guide. If the tube is meant to evacuate a pneumothorax, aim it apically towards the top of the lung. If the indication is to drain fluid, aim it basally towards the bottom of the lung. Make note of the depth the tube has passed by keeping track of the numerical markings on the side of the tube. Secure the chest tube to the skin using the heavy sutures. Simple interrupted or mattress sutures are often satisfactory to ensure stability of the tube and avoidance of air leaks around the tube. The free ends of the sutures are wrapped around the tube and tied multiple times to secure it in place. Purse string sutures are not recommended as they yield poor cosmetic results and increase the risk of skin necrosis. Once the chest tube has been secured, a petroleum-based gauze dressing should be wrapped around it. Apply several pieces of sterile gauze around the tube. Secure the site with multiple pressure dressings. A chest X-ray must be done to confirm correct placement. On an X-ray, the radio-opaque stripe is visible with an interruption indicating the position of the proximal hole. This hole must be within the pleural space. Otherwise, it is sitting outside the pleura and not draining effectively. This is an indication to replace the tube altogether. Do not advance the tube into the chest, as this can introduce non-sterile tubing into the chest cavity. Before unclamping the free end of the chest tube, firmly connect it to the sterile drainage system. Now unclamp the free end. If pleural fluid is being drained, the fluid level of the drainage system will rise. If a pneumothorax is being evacuated, air bubbles will appear. Do not reclamp the chest tube while there is bubbling. This may lead to recollection of a pneumothorax and may even result in a tension pneumothorax. Most commercially available drainage systems use the 3-bottle model of closed drainage and suction. The most important bottle is the underwater seal, which serves as a one-way valve that allows air and fluid to leave the pleural cavity without the risk of re-entry during inspiration. All available pleural drainage systems contain the underwater seal bottle. Bubbling may be seen in this bottle. This will indicate whether there is an ongoing air leak either from the patient or from the system itself. The two other bottles that may be present in the drainage system are a collection bottle connected directly to the patient for accumulation of pleural fluid and or debris, and a suction system that connects to wall suction or regulates the amount of suction actually delivered to the pleural space via a column of sterile water. Suction may be applied if there is a persistent pneumothorax despite the underwater seal, or if a viscous pleural collection is not draining effectively. When evacuating chronic large pleural effusions, the risk of re-expansion pulmonary edema has been well described. A stepwise approach to the drainage of chronic large pleural effusions is recommended, not exceeding 1 to 1.5 liters within a 30-minute period. The pleural drainage system must be kept approximately 40 inches below the patient in order to prevent retrograde flow of air or fluid back into the pleural space. There are complications associated with the insertion of the chest tube. These include bleeding and hemothorax, traumatic perforation of the lungs, heart chambers, diaphragm, or intra-abdominal organs, intercostal neuralgia due to trauma of the intercostal neurovascular bundle, intermittent blocking of the tube with clot or debris, subcutaneous emphysema, re-expansion pulmonary edema due to more than 1 to 1.5 liters of fluid drainage in less than 30 minutes, infection of the drain site, and empyema. The timing of chest tube removal depends on the indications for the chest tube. In the case of a pneumothorax, bubbling must have ceased, the patient stabilized clinically, and the lung re-expanded on a chest X-ray as minimal criteria to remove the tube. If suction is being applied to evacuate the pneumothorax, most clinicians perform a trial of underwater seal alone in order to ensure there is no further bubbling with the suction turned off. Most physicians will perform a chest X-ray 12 to 24 hours after the last evidence of the air leak prior to removing the tube. The decision to clamp the chest tube to check for a persistent air leak is one that is practitioner dependent, and there is insufficient data to support or refute this practice. If the chest tube was placed to drain pleural fluid, once the drainage volume is less than 200 cc's in a 24-hour period, and the fluid is serous, the tube may be removed. If a chest tube was placed for empyema, removal of the tube should be considered only after the patient has stabilized clinically and the drainage criteria are met. If an air leak is persistent, or the pleural fluid drainage criteria are not met, a pulmonary specialist or thoracic surgeon should be consulted for a definitive, potentially surgical management. Pneumothorax risk is no different after chest tube removal during end inspiration versus end expiration. Once the sutures are removed, instruct and await patient to hold his or her breath either after a full inspiration or full expiration, or while performing a Valsalva maneuver. Hold the tube at end expiration if the patient is being mechanically ventilated. Ideally, 2 clinicians should be present during tube removal. Once the tube is removed, quickly seal the incision site with a petroleum-based gauze, reinforced with several pieces of regular gauze on top of it. Secure the site with a pressure dressing. Additional sutures may be required to close the incision. A follow-up chest x-ray should be obtained 12 to 24 hours after the tube has been removed. Closely inspect for any suggestion of a new pneumothorax. Caution must be exercised when removing a chest tube from any patient on a mechanical ventilator, especially in those with high oxygen or positive pressure requirements, chronic lung disease, or other risks for recurrent pneumothorax. Experienced physicians should supervise the decision to remove the tube in these cases. The insertion of a chest tube is often done under extremely critical circumstances. However, using the appropriate techniques and sterile precautions will ensure safe and efficient performance.
Okay, that was fun. Troubleshooting the system. Obviously, you want to go from the patient end back to the drainage unit itself, just like you would with the mechanical ventilator. Always start with the patient. As far as assessment of the patient, things like development of subcutaneous emphysema, what their vital signs are, any chest pain that they're complaining about, presence of or absence of breath sounds, and looking at the site to see if there's excessive bleeding at it. The tubing component of it, with the suction turned off, we can assess whether or not there's the presence of Tidaling or not. If there is some leak still there, making sure that the connections of the tubing are tight, and if necessary, securing them with tape. The drainage unit itself should make sure that the suction chamber has the appropriate amount of water in it to limit the amount of suction, and as well as the water seal is present. More than 100 milliliters an hour is significant drainage. So if we have a situation where a patient has greater than that amount, are probably not a good candidate to begin weaning from the ventilator. Looking at the amount of bubbling that is present, and looking at the chest wall suction. We talked about clamping the tube being a bad thing. This is something obviously the physician is going to be the ultimate one doing. Sometimes you need to clamp to find the source of the leak to make sure it's not something within the tubing itself. If you need to change the drainage system because it's full, you're going to need to clamp the tube at that point. But often it's only done to verify that you have a lung that's expanded, so I can now remove it. When there's no more drainage, when there's no more Tidaling, when there's relief of dyspnea, and when the x-ray shows re-expansion, we'll go ahead and remove it. There's kind of the directions that they talked about in the video. Just for informational purposes, this is kind of a neat one. It actually has a little sensor to quantify the amount of leak that is ending up being present. I've never seen one of these, but it looked kind of cool. So, troubleshooting. One of the problems that we encounter, especially with a bronchopleural fistula, where there's a connection between one of the larger bronchi and the associated pleura, we end up having basically tidal volume lost through the chest tube. So as you're putting air into the lungs, it's immediately going right out the chest tube. It's just kind of a frustrating mechanism because you're not effectively ventilating that patient. And often we just overventilate. We just increase the tidal volume to a higher level to try and identify how much air is being lost. And again, we can document that by looking at the volume time tracing on a waveform. Clots will end up having no bubbling in the water seal and no titling, and sometimes just changing the patient's position will go ahead and shift that. Some people advocate using what they call stripping the chest tube, where you run your hand along the rubber portion of the chest tube to kind of create a little bit more of a vacuum. See, I've seen that done. If you have large changes in titling, there's a lot of movement up and down the tube. That's often a sign of work of breathing being increased. Obviously, it's something that we should be picking up by looking at other parameters like the respiratory rate and the pulse oximeter level. But again, assess the drainage system, assess the ventilator settings, assess the patient, make sure there's not something incorrect there. If I have no titling, it could be that the lung is re-expanded. Wonderful. Could also be that we have obstruction present. And this is as far as locating a leak. One indication for clamping it to verify that the leak is in the chest and not inside the tube itself, the tubing itself, and could be the drainage unit also. Replacing the drainage unit obviously is going to require the clamping to occur. Low levels of water will limit the amount of suction that is applied, so you need to replenish that within the suction chamber to get to the correct level so that you're at the spot that you want to be. If the chest tube comes out, cover with a sterile dressing. If they're on a mechanical ventilator, you can just leave it open because the positive pressure is going to push whatever. It's not going to promote the accumulation of fluid, or of air inside the pleural space. The positive pressure breath will push it out. So here's some, and I believe I took these from that article that you have. Maybe I didn't. I don't know. It's been a while since I looked at it. But in a short period of time, there's over an hour's period of time of a huge amount of loss. This is one where basically patient could be going to hypovolemic shock, and we need to find out where the source of the bleeding is. And in most cases, they'll just take them back to the OR and reopen it back up to see if they have a bleeder present in the process. But 100 milliliters an hour is considered the cutoff. Anything greater than that is considered significant. Here's where my original water fluid is. Now I have an additional stuff here. This is really a one bottle system, but unfortunately they have drainage going on. And then in that case, the system should be replaced with a separate collection bottle and a separate water seal, either 2 or more commonly a 3-bottle system. If I have a suction that is very low, I'm not going to have a whole lot of air being removed. So in that case, I need to add additional water in my suction level, because this distance here literally is how much vacuum you're applying. However many centimeters that is the only amount of vacuum. You can have the suction source turned up to 100 millimeters of mercury. It's only going to be limited by that depth. So you want to make sure that that depth is kept on a correct level.
Why don't you just adjust the suction of the wall rather than having that depth as your suction?
This is kind of a fail-safe, so that if somebody inadvertently turns the wall suction up to a higher level, it's not going to cause that much vacuum inside the interpleural space. It's a safety feature. What's wrong here? You can't drain when it's sitting above the patient. So it should be put roughly 40 inches below, 3 feet below the patient. Picture A, picture B. Picture A shows some normal bubbling. Picture B shows excessive bubbling in the water seal bottle, and that's basically a sign of a leak someplace that you'll need to identify. Is it inside the patient still, or is it something where it's leaking in the system itself? Excessive bubbling in the suction bottle probably means that I have that turned up too high. There's no need to have it that high. It's still only going to be limited by what that depth is as far as what the patient is actually exposed to. But you'll see sometimes those chest tubes just bubbling like they're going crazy. It's like, dude, we don't need that suction probably put up that high. If there's no bubbling in the suction control, yeah, well, it's in my it's hooked up to suction, and it should increase the suction level until you get some gentle bubbling present within that suction source bottle. I don't know if you've seen this one or not.
Oh my god.
A first grade girl handed in the drawing below for a homework assignment. After it was graded and the child brought it home, she returned to school the next day with the following note. Dear Ms. Davis, I want to be very clear on my child's illustration. It is not of me on a dance pole, on a stage in a strip joint. I work at Home Depot, and it commented to my daughter how much money we made in the recent snowstorm. The photo is of me selling a snow shovel.
Oh my gosh.
And there's actually mugs you can buy.
Oh my.
Okay, that's